see. Advanced airway management. We're going to talk in the beginning just about endotracheal intubation. How many of you guys have gotten a live intubation? Anybody? Yeah? How'd it go? Were you successful? First time? Yo. Yeah? Excellent. Was it what you thought it was going to be? Were you nervous?
I have a question. This is kind of about something I haven't worked yesterday. We intubated a patient.
Where? At work? Is that what you said?
Yeah.
Or? Okay.
And
at the hospital.
And when they intubated him, he like started having, they got it in, but he like started having bronchospasms. Like we had to cancel the case. We were in the room for like 2 flipping hours. What happens if that happens on a truck? It's like they were having trouble ventilating. I mean, there was like 2 anesthesia doctors in there. It was ridiculous.
Did they RSI him? They paralyze him? Once you do that, you shouldn't have those bronchospasms. No? Whew, that's scary.
Yeah.
Things like that happen. Sometimes a patient can have a response to the tube, the plastic in the tube, or the spray, if they use some kind of spray to deaden that, or if they lubricate the tube, if he has an allergic reaction to that material that they put on the tube, that could cause like an anaphylactic reaction. Did they think it might have been like that?
They were going to send him to a pulmonologist.
Yeah.
Because they were just kind of like
freaking out.
He was overweight, but he didn't really have any health problems.
Yeah. I would guess he just had a laryngospasm, or was there swelling in the airway too? No?
It was just, like, they said he was just having bronchospasms, and, like, they couldn't ventilate, and then it would kind of break, and then it'd come back.
And you had anesthesiologists in there, and they couldn't figure that one out? You know, for us, someone calls 911, it's really their problem. We do everything that we can, but we're not responsible if something weird like that happens on the truck. You know, we just do the best that we can with what we have and try to get them to the ER as quickly as possible. But, you know, in that case, all you can do is, did they consider cracking the guy? Or I guess that would have mattered, because it was a bronchospasm.
Because I asked that question.
Yeah, not a lot they could do then.
Yeah. They gave him like 6 breathing treatments through the tube.
Oh, yeah.
And they finally got it to break, but it was just
scary, huh?
Yeah.
That's weird. There's all kinds of weird stuff out there, I guess. So there weren't no fluid in the lungs or anything, just a bronchospasm. That's interesting. We're going to talk briefly about endotracheal intubation. I'm glad some of you guys have gotten a live intubation. That kind of makes it a little bit more interesting for you. Times that we'll consider intubation will be, of course, cardiac or respiratory arrest. Any patient that's unconscious, why would you intubate a patient purely because they're unconscious?
Control of the airway.
Yeah, you get full control out of the airway. We say less than 8 intubate. Less than 8 is what? What would that be? What am I talking about when I say 8? You know, the Glasgow Coma scale, that's right. Because if they're completely unconscious, then no, they're not able to protect their airway. However, if they're just unconscious, say they're, some diabetic issue or something, or they're just unconscious, then if they're breathing adequately, you're probably not going to intubate, because there's always going to be some type of risk involved with that. So make sure you're doing it for the best interest of the patient, not just because you need an intubation. I've seen that happen. If there's a risk of aspiration, then yeah, intubate is a good move there. Obstruction of foreign bodies, trauma, burns, anaphylaxis. Particularly with the burn, you want to try to intubate early, because as that tissue continues to swell, you're not going to be able to get that intubation. Anaphylaxis, hopefully we can break that without a problem, hopefully. Respiratory extremis due to disease. What does that mean? Extremis? Respiratory extremis? That's where their disease has really gone to the next level. You have somebody with COPD and all of a sudden they have an acute exacerbation of that disease. Same thing with asthma. You just can't break that asthma attack. You could consider intubation. With an acute asthma attack, and after you've done all of your drugs, you're suffering the trouble with it, what can you try? CPAP. Yeah, CPAP you can use with asthma, and oftentimes it's successful. Pneumothorax, hemothorax. What do you have to be careful of if you have a patient with a pneumothorax? Well, you do have to worry about overinflation. You know, if you're putting too much air in there, you run the risk of, you know, doing more damage. So if you've got a hole in the lung and you're putting a whole bunch of air in there, you know, you're putting 1,200 cc's in there, that air's got to go somewhere. Where's it going to go? Either into the chest, if that's the path of least resistance, or come around into the esophagus, but more than likely you're going to get it going into the chest, and we want to avoid that whenever possible. Advantages of intubation: of course, it secures the airway. It limits gastric distension to some degree. You have a little bit more control over what you're doing, and the air doesn't typically go into the stomach unless you overventilate. But you know, when you're bagging a patient, just because of the way you've got the two tubes there, it's very easy to put air into the stomach. You can suction through the ET tube, and you know, all the textbooks tell you, the documentation tells you that you can put medications down the ET tube. You can put medications down the ET tube, but there's no documentation anywhere, well, as of last year, that it works. You know, you put it down there, it doesn't hurt the patient, but the absorption just isn't there.
It seems like you'd be forcing them to aspirate. I mean, I recognize this, if there's the blood vessels in the lungs that can absorb it, but it seems like, especially when it says to put like flush it with saline, it's like,
You actually,
almost like you're drowning the patient.
it sounds like it is, but you can put probably 10 or 15 cc's in the lungs without them having any negative response. The problem you get is if you aspirate food products, where it's got all that acid in there, partially digested food that just will eat away the alveoli, that's your biggest danger. But a little bit of fluid in the lungs like that we're putting out the tube, the lungs manage that fairly well without a problem. That used to bother me too. I used to worry about that. So you can put medications down there, but it's not very effective. So you want to get the IV. Do not use the tube. If you can, you know, do the IO or get an IV, that's going to be your premier way. Don't depend on having your patient have a good outcome based on you putting medications down the tube. It just it doesn't do anything for them. Disadvantages: you need a lot of intubations in order to stay good with it. You know, if you get one intubation a year, it's hard for you to stay good and proficient. So that's one of the problems with intubation. And that's one of the reasons that we didn't give it to the advanced EMTs. Because now you've got, you know, many thousands of people trying to get one tube. As long as they confine it, you know, to the paramedic population, then you're going to get more skilled practitioners. You want to? God, there's just so much to know. So you see the strip. I don't have a problem with them running the strip, but interpretation of giving meds, that scares me. I know some of those people. I know some of those in my EMT class. Oh my gosh. We pray they don't get licensed, okay? Do I need to pray about anything? Wait, some of those people don't pass, okay? Oh, we're recording this. I hope they don't pass. For most intubation, you should have direct visualization of the cords. As you know, we talked about other ways that you can intubate without direct visualization, but that's really the best way to do that. Complications: there are a lot of complications. You broken any teeth yet when you're doing this? A lot of you patients, as you're intubating, you're in cardiac arrest, they have very poor dental health as well as overall health. And I've seen it quite a few times where teeth are like just breaking and going down the tube, or down, not the tube, down the mouth. So there's a lot of risk to endotracheal intubation. You can do a right stem intubation. You can overinflate because of pneumothorax, tension pneumothorax. Okay, as you know, the different blades, y'all picked out your primary little blade, so we're not going to spend a lot of time on that. But you do know the Miller goes under the epiglottis, and where does the MAC go? In the vallecula, that's right. Okay. Are y'all familiar with the endotrawl? The ring tube? I think we talked about it in here.
Yeah, we all missed it on that test.
Yeah, I've got some downstairs, so if we go down there after lunch, I'll show it to you. What do we use this for? See that little ring? That's what I call a ring tube. Yeah, it lifts the tip, so it's much easier for you to hit the trachea versus the what do we call it? Esophagus. God, I can't talk this morning. But primarily, what do we use this for? What's its specific purpose? You missed that one, so I thought you studied that one. Okay, these are specifically made for nasal intubations. You know, because you're not viewing the vocal cords. So as you put this in, you've got that little ring right there, and you can thread that into the trachea without seeing it. You know, if you pull on that tube and that end comes way up, it's hard to get that thing into the gut. So it's very handy for that. And it's inexpensive. I know all this stuff. Have y'all, anybody used the McGill forceps on a patient yet? What would you use those for? Yeah, if they've got a foreign body, and sometimes you don't think about that, but if something's lodged in there, you can stick those babies in there. Even if you use your laryngoscope, you look in there, you see it, you snatch it and go. It's great. I pulled a little bullet casing out of a 1-year-old with those. Hyperventilate. Always make sure you pre-oxygenate the patient, because we forget how much time we're spending trying to get that tube in there. So make sure that they're hyper-oxygenated, and then count to make sure you don't take too much time. Visualize. I think that's a cool picture of the cords. So is this guy breathing or not? Okay. They're closed. When do the vocal cords close? When does the glottic fit? When does the glottic opening close? The glottis, epiglottis. Man, I can't talk today. The epiglottis. When does the epiglottis close? When you're swallowing. Otherwise, it stays open. Hit the cuff, auscultate, confirm, secure, reconfirm. Anytime you move a patient, you need to reconfirm breath sounds. Every single time. If you put them on the backboard after they're intubated, which you may do, if you've got a cardiac arrest, you may work your code. Now you're ready to put them on a long spine board. Why do you put him on the long spine board if he doesn't have a spinal injury? Yeah, you need a firm surface to do CPR, and it also keeps him contained. Makes him very easy to move. So when you roll him up, put him on the board, you got to reconfirm breath sounds. You move him up and put him on your stretcher now, reconfirm breath sounds. You know, when you get out of the ER, one of the first things you want to do when you roll them in, put them on that bed, you confirm breath sounds, you have somebody there reconfirm breath sounds. And then document who confirmed it. It's a big deal. They've got some lighted endotracheal devices now where you can actually see that little light as you slide it down, and you just slide your, this doesn't show it, you just slide your tube over that. It's almost like a bougie. Now with these, you can intubate, you don't have to be over the head. You don't really have to have a laryngoscope. Here I think they're going to show you to do it like a digital intubation. Yeah, and we talked about doing a digital intubation. We practice those in here when you go down. You need to do that. They're extremely handy. My first intubation in the field was a digital intubation. It was the olden days. But you just lift up the epiglottis and you just feed that in there. If you've got your middle finger holding up that epiglottis and you slide that tube right by it, you can't miss. I say that. You shouldn't miss. Here you can see the little light shining through, and you know you're in the trachea if you can see that light. This is digital intubation. See how you're facing the patient. He's going to walk his fingers down there and grab the epiglottis and slide that tube between his fingers to hit the right spot there. He's going to lift the epiglottis. Y'all should try this on your patients. You got a dead guy, you're doing working a code, try this. He won't bite you. That's always important. Okay, sometimes you may have to intubate a patient and hold spinal precautions. A good way to do this, of course, would be to put a C-collar on. This kind of helps you remind you and have somebody help you hold their head stable. But it's not a guarantee by any stretch of the imagination. You may just have somebody hold the head, whatever works for you. Selleck's maneuver is helpful here because it's going to bring the cords down in line so you can see them better. We don't really use that so much for regurgitation purposes, you know, to prevent regurgitation, but we will use it to bring the vocal cords in line. Ventilate your patient, of course. Reconfirm placement. Okay, RSI, we talked about this back in the spring. As you know, Alabama's passed some new protocols. They haven't been published yet because they're still going through the approval process. But one of the items that they've added is going to be RSI in certain circumstances. And they're gonna make sure that any medics that are approved to do RSI have, I think it's at least 3 years of experience in a high volume setting, which is good. But we talked about that, but if your service is required to train you on that, if you personally get approved to do that, they're required to train you on that. So make sure that they do. Because every service is going to do it a little bit different. And then the state's going to set those protocols. Like I said, they're not published yet, so we don't have the exact treatment protocol of what drugs they're going to want to use, what dosages they're going to want to use. So all that's yet to be published. But in what circumstances would you want to use RSI? What types of patients first would you use this on? What?
Burn patients.
A burn patient because they're what?
Well, if you're trying to protect the airway and they're still semi-conscious.
Yeah, if there's a level of consciousness there, if they still have a gag reflex, and you feel like you emergently need to intubate them, then you're going to have to paralyze them to do that. And you know, there's 2 components to RSI, right? It's drug-wise. What are they? Do what?
Sedation.
Succinylcholine, is that what you're trying to say? Yes, sedation and then paralysis. And you need both of those. Can you imagine being intubated while can you imagine being paralyzed and you can still, you still have your consciousness? You know what's going on, you know, you can feel everything. That's got to be the scariest thing just about on earth. So make sure that you take those extra probably 30 seconds to sedate them before you paralyze them. But what's the most important component of any of this before you paralyze a patient? You have to be able to do what? You have to be able to ventilate them. If you paralyze that patient and you can't get the tube in, or you know something goes wrong there, you've got to be able to ventilate them. So if you're having trouble ventilating them before, you're probably going to have trouble ventilating them after. But you got to know you get that tube in before you paralyze them. One of the reasons we use succinylcholine specifically rather than other drugs is what? Do you remember?
It wears off in like 90 seconds.
Yeah, it wears off really quickly. It paralyzes them long enough for you to get that tube in. You know, usually they talk about, you know, you've got a 3 or 4 minute window there where you're going to have to be able to, you know, until it completely wears off, where you're going to have to be able to ventilate them. So that's why we use succinylcholine. Okay, so what have we got here? This is just a list. I'm going to post this in case any of this interests you. You need to know what these drugs you use for. We use Versed. I think we're carrying Versed, so that you can use that as a sedative. Some disadvantages: it causes hypotension. So if they're already hypotensive, you may want to consider something else. Etomidate. Are we carrying etomidate now? Okay, we carried it in Florida. That's a great. They may add that as one of our induction agents. Ketamine. We're not carrying ketamine yet, are we? Okay. We'll probably carry that as part of it. All right. Other sedatives. Now, these are not sedatives, but these are other agents. What do we use atropine for a patient that we're doing RSI? Yeah, that's going to dry out the secretions. It also, particularly in pediatric patients, who when you stimulate the back of their throat when you're trying to intubate them, they very frequently will brady down. So atropine will help counteract and prevent that braiding down of your pediatric patients. Lidocaine we give when we're having to intubate a patient RSI when they've had a head injury. So know those. Atropine for pediatric patients so they don't brady down, and then lidocaine for your head injury patients. All right, pediatric patients, these are things that you already know about their airway. Of course, it's smaller, it's more flexible. Probably the biggest things you need to remember about a pediatric patient is where their trachea, their larynx, their epiglottis are actually located. With an adult patient, you know, when we tip our head back, the airway is pretty much straight. With a pediatric patient, their airway kind of comes up like this. So when you tip the head back, you're making that angle much greater. That's why we don't tip it back. With a pediatric patient, how are you going to get a neutral airway? You got a pad under the shoulders for that very reason. Their airway is more anterior. You know, when you lay them down, it's much higher, it's closer to the mouth area, so it's harder to visualize that. But once you see it, it's pretty easy to get. The epiglottis is very floppy. So which blade do we usually use with that?
Miller for kids.
Yeah, we're usually going to use the Miller for kids because you actually slide it under the epiglottis and you can hold that out of the way. With the Mac, you put it in the vernacular, when you lift that up, that big old floppy epiglottis, it's like one of those, older women with big old boobs, you sling them over the shoulder so you can do it 12 lead. It's kind of like that with their epiglottis. It just like hangs and flops. And trying to get that out of the way so you can see is quite a challenge. Okay, a little visual for you. Anyway, also with pediatric airway, the cricoid cartilage is going to be the most narrow part of the airway. Why is that significant?
We use uncuffed tube.
Well, we'll use the uncuffed tube for that because that cricoid keeps it tight in there. But the other thing with that being so, the smallest part, that means up here is the biggest part. So they're more prone to get stuff down there and it gets trapped with the cricoid, which is pretty low in the airway here. With adults, what's the smallest part of the adult airway? Starts with a G. The glottic opening. Yes, we don't get that crap down our airway most of the time. Most of the time. With pediatric patients, make sure that the size of the bag is the correct size for your patient. All those parts are interchangeable. You can put a pediatric mask with a giant adult bag, and you want to avoid that unless you're ventilating an adult patient. With a child, you get a big bag, you're going to overinflate them, and that's never a good thing. What happens if you overinflate? You may get a pneumothorax, you pop a lung, what else?
We're not really having good ventilation or exchange.
Good gas exchange if you pop a lung. That's for sure. Pop a lung. Yeah, if you put too much air in there, you're going to get gastric distension, which is never good either, right? What happens when you get too much air in the stomach? What, they vomit? Yeah, I hate that. I hate that vomit thing. But what else happens inside the chest? Stomach gets really big, lungs can't inflate. What else can't inflate and deflate? Inflate's probably not the right word. Expand and contract. The heart. Yes, it really interferes with the working of the heart. What I say something funny? Or y'all say something funny? Okay, I didn't do anything nasty, but I don't know what I said. Okay, to determine the size of the ET tube, this is a formula you need to know because you may see it on registry. And they may ask you to figure the size. The size is going to be the patient's age in years, say 4-year-old, plus 16, how much is that? 20, divided by 4, 5. So it's going to be a size 5. So with a child, would you probably sit there and work out this formula? Probably not so much because kids, I've got a 7-year-old grandson and he's from a short family. The other side, they're really short. But he's the tallest one on his flag football team. He's like this. But there's a kid on there that's 7 and he's like this. I think he's from the midget family. So yeah, you can get a 7-year-old, 4-year-old that's, a wide disparity. So is this really effective? Who knows? What's probably a nice, easy way to use? Their pinky, not your pinky. Their pinky. It's pretty good average. Okay, here's just a little thing. Thinking about that. Intubation in a child. Same things. We're not talking about children anymore. When would you use a nasal intubation? Number one, what kind of patient? One thing that has to be in place if you're going to do a nasal intubation. They got to be breathing. Did you study this? They got to be breathing because that epiglottis has to be open. So they have to be breathing spontaneously. They don't have to be breathing great. You really could have agonal breathing. You just got to catch that breath so you can slide that tube in. So what circumstances would you want to do a nasal intubation?
Christmas.
Those? Trismus? What's Trismus?
When the teeth are clenched, like what?
When the teeth are clenched. When the teeth are clenched, that's Trismus. Would be a perfect time to do that. What else?
Obstruction.
With it probably wouldn't matter one way or the other. Is that on there? You may use this, say if you've got a patient that you're unable to visualize the chords. Sometimes, and you may have seen these patients, they're so large, you know, you're trying to visualize the airway and it's really occluded because of all the tissue there. In that case, doing a nasal intubation may be effective. Doing a digital intubation may work for you pretty well. With a naso, if you're able to do it in the presence of a spinal injury, it works quite well. Don't have to tip the head back. Of course, you don't get the gag response that you get with a oral intubation or anything else. They're easy to secure. I mean, where's it going to go? You got it in their nose. Just take that baby down. It's not a problem. Of course, they don't bite it, which is always nice. It can be time consuming. The first time you do it, it just scares the wits out of you because you're thinking, I'm never going to get that tube in. But if you're listening, you've got one of those little BAM devices where it whistles as you get close to the airway. It'll whistle and you know you're right there. You can slide that baby in. Especially if you've got a ring tube. If you're pushing through your tube, you've got that ring and you're listening. You've got a little BAM device you can put on the end and you can listen to that air. You can slide it right in. And you know immediately if you're in because it'll whistle really good. You know, it's kind of like your colorimetric. It's going to change colors. This is just, it's going to walk you through the steps here, I think. Is he looking down the tube? That's pretty odd. Don't look down that tube. You need to listen with that. Quickly, we're just going to go through, this is a combi tube here, isn't it? Looks kind of like it. Well, sort of like it, except that big balloon thing, I guess. That looks weird. Combi tubes, you're going to have those. It's some type of alternate airway device, and they're always coming out with new things. What do y'all carry on your trucks? The King, yeah, most places have gone to the King. You know, you can place it anywhere. Advantages and disadvantages, it's really fast. Even the EMTs can do it. But you still have to monitor what you're doing. You still got to monitor for breath sounds, because if you start ventilating the wrong tube, you know, you just have a big brain fart that day, and you know, put it on the blue instead of the clear, it's like, ugh. How would you recognize that you were in the gut instead of the lungs? Yeah, say you forget to listen. All of a sudden, yeah, all of a sudden it's like, man, it's going to explode. You think it's because we got the tube in the wrong place? Other intubation devices, there are all sorts of things out there. Be familiar with them because you may see one registry. It may say, in which circumstances would you use a PTL? You're going, what's a PTL? So just kind of know, look at these letters and kind of know that these are other devices that you can use. They're not really intubation devices, but there are airway devices. This is an LMA. Where do they use the LMA most commonly?
Surgery.
In surgery, yeah. They make them now, so we can use them on the trucks. In some areas they do use them. I don't think we use them yet. But they're pretty handy. They're probably a little bit better than a combi tube, but there are some disadvantages to it. But you can, it looks really bad, but this little device just fits right over the larynx, you know, right at the glottic opening. It just fits on there, and then you blow that up, and you don't have to worry about anything going into the stomach at all. So
We have some now that you don't even have to blow up.
Really? Just slide them
New
on.
ones that just came out.
How do they get them fitted? Or what holds them in
They
place?
stuff them, like it's pretty much use the biggest size you can use, and they
Just
put
get it in there.
KY on it and just,
Just let it rip.
yeah.
I'm all about it. We may be doing that someday. Of course, for us, you can't suction through that. You know, you can suction through an ET tube. You're not going to be able to suction through the other devices. Now, if you use the combi tube, though, you can suction, you know, the esophagus, and you can, you know, deflate the stomach with that. So I mentioned a minute ago using the, what are the little clippy things that we use to get a foreign object out of the gills? Okay, just check it out. Here's just an example of how you do that with a laryngoscope. You can see it and get it. That's really useful sometimes. You know, if they've got something blocking the airway, you're gonna be able to intubate without pushing it on down, or even then it may not work for you. Okay, let's talk about surgical airways. How are we doing so far? Not doing too bad. When would you use a surgical airway? When all else fails. Yeah, you can't ventilate them, there's something stuck in there. As we said, we only use this if it's a bronchial spasm, right? So if you can't pass air through here, then you may consider it. And we are getting that in Alabama. That's one of the things in the new protocols.
What?
Yeah, pretty sure.
I thought we had the new,
Yeah, I mean, there's several ways you can go about it. There's a lot of different devices. I can't remember the one that I have here. But you may actually do what we call open cric, where you take the scalpel and cut it open and do that. Or you may have like it's almost like a catheter, an IV catheter, but it's much larger that you stick it in, pull the inside out, and fit it that way. But if your patient can't breathe and they're turning cyanotic, you've done everything you possibly can, this is not a permanent thing, you know. They can clear it up, sew it up, you're all good to go. I don't think they sew it up, maybe they do. Anyway, the landmarks. Remember the anatomy we've got here, right? Let's see what we remember. What's this one right up here? Thyroid cartilage. What's this? Starts with a C. Cricothyroid membrane, and this is what? Cricoid cartilage. So there's a space in between here that you'll be able to palpate that you're going to go right in. I'm going to show you that later because I got some really good videos of it. But once you identify it, you're going to have to pin it down so it doesn't move. So you're going to place your fingers, your thumb and your finger of your less dominant hand, and you're going to hold that down before you do your stick. You can see how they're holding it down. Now this guy, he's just doing a puncture, and I think this is the kit that I have. You go in, we'll kind of go through that. This is a better picture. You don't go in real far because you don't want to go into the esophagus, right? But you'll know when you hit that, it's kind of like when, you know, just when you're doing an IV stick, you'll feel that puncture as you go through the vessel, and then it gets real easy to move. So you'll know that. And once you pull your stylet out, what do we call that thing? You'll hear air move. Now I mentioned the open cric. That's where you're actually going to take your scalpel and cut there. I have a really good video of that we're going to show in just a few minutes. You just make a small incision, a couple centimeters up and down, long ways, right there at that membrane. Now sometimes they'll tell you to come back and make a little cross one, depending on what your equipment is like. Some of the equipment, you won't have to do that. You'll have something that'll kind of twist around. But if you're just using a scalpel, you'll need to go a long one up and down, then a short one across. Now you'll have some kind of a hook, or a hemostat, I forget what they call that thing, that it hooks on there, and you'll pull that so that you're going to get access. But you're going to keep your finger in there to hold that place. Once you have obtained access to the trachea, you need to keep your finger in there, even though you're pulling that back with your hemostat, so that you don't lose that place, because it'll close up on you if you're not paying attention. Now once you've got that open and ready to go, you can use a regular ET tube. You might cut that off because you don't need this long thing hanging out. But there's something called a Shiley. They're about a 6.0 also, and it's just a little mini ET tube. You know, it's got the adapter on the end. It's got the little balloon on there. So you place that. This is a Shiley here. You place that and inflate the tube so it doesn't move anymore. And then how do you confirm placement? Yep, same way as you would any other way. You're going to use a colorimetric device. You're going to use capnography. Ventilate your patient. Is the ventilation rate going to change? No. Some people think that. Do you have to tip the head back when you do this? No. That's one of the nice things about it. It's easy to use in a trauma patient. Patient with a stoma, let's see. You know, patients with stomas create a lot of mucus. They lose a lot of that cilia, the little hairs that move that stuff up as a consequence of their disease. so they're not able to evacuate their lungs very well. So it's very common that you're going to have to suction them. What's going to be your technique to suction them? What are you going to start off with first, usually? Do what?
Kind of like,
Yeah, we got to suction this guy. He's got a stoma. You can just hear that rattling. He's got snot in there. It's just moving up and down.
the yank that little hard too.
A yonker oh, what you're saying. Yeah, well, you wouldn't use a yonker with that, but you would use a flexible French catheter. First thing you want to do is instill a little bit of normal saline or sterile saline or sterile water in there. Probably about 2 to 4 cc's, because that helps to break up that mucus. So you just put it in a little catheter and you just squirt it down in there, and then let it sit for a few seconds. Then you start suctioning that out with a little French catheter. This is just some of the tracheostomy cannulas that you may see. This was the Shiley that we saw just a minute ago, but there are all sorts of different ones that may be used. This little device goes inside this device. So we're really just looking at 2 different devices here. I said about suction. Y'all already know that. Gastric distension. Did y'all talk about putting in a NG tube? Have y'all done that in the ER yet? That's kind of cool. Y'all do it. Do you ever do it in surgery? Yeah. The best way is going to be probably going down the nose. And it's important that your patient swallow. If they have a consciousness level, that you can get them to swallow. Why is that important? Yeah, you don't want that to go into the trachea. You want that to go into the stomach. And if they don't swallow, it's not going to go into the stomach. I honestly had a patient one time feed it down and said, okay, I need you to swallow, swallow, swallow. I mean, we had a tube about this long, and I said, okay, keep swallowing, swallowing. All of a sudden he opens his mouth and this big old tube comes out. I'm going, you idiot, I told you to swallow this. So of course then we had to pull it right back out of his nose. So, okay, well here goes. Next time when you swallow it, so they need to sit up, kind of with the head forward a little bit, nose down as you feed that food. Make sure you lubricate it and tell your patient, this is going to get all that crap out of your stomach, so I need you to swallow this. Or we're going to do it again and again until you do it. You can use this to evacuate the stomach of air or stomach contents, depending on what the issue is. So it's not always just used for patient in cardiac arrest, but for a lot of different reasons. Okay, I already told you that. Oxygen. Now, I put this up here just so that you'll be familiar with it. But you shouldn't have questions on registry where they ask you what the C factor is. I can never remember that. But you know that a big tank's going to last longer than a little tank, right? Okay, but just recognize you can't figure out how long that tank is going to last unless you have the C factor. But it is kind of interesting to work this out sometime. But it's there if you're interested in it. Oxygen delivery devices, even though we only use 2 or 3 of these, you're responsible for being familiar with a simple face mask, a Venturi mask, partial face mask, and kind of get a feel for where they're used. We don't use those, hopefully. Got that, and that. Y'all have all seen the demand valve mask, right? We don't carry those, but you can. The nice thing about these is it's not going to be blowing air all over your patient. If you use it on there, when they start to breathe, it opens up the diaphragm and it allows air to come in. Otherwise, it's not blowing all over. Mechanical ventilators. I review this just because controlling the airway and managing the airway is the most important thing you can do. Even though you won't commonly use many of these ALS interventions, you need to know how to use them and move forward with them. I find that, particularly when you're new at it and you hadn't done it, you're a little bit scared to jump in and do it. But you know what? That first time you drop that nasal intubation or you do that digital intubation, you go, yeah, I can do this, and you can see the benefit of doing it. First time you put CPAP on a patient and they go from being blue and fixing to die and the eyes rolling back in their head to they're sitting up going, hey, I'm good. Don't take me to the ER. Take me home now. And you really can see a turnaround in your patient. So be aggressive with these when it's called for. If your patient's circling the drain, you may have waited a little bit too late. So anyway, let's take a short break. It's 25 after. What do y'all need? You want 10 minutes, 5 minutes? What do you want here? What you gotta do? That's good. Come back about 25 till, and then I've got some videos I'm gonna show you, and, before it's over this morning, y'all gonna take your operations test, because y'all all prepared for that, right? And then the other group will take it next week. We do that, make sure you don't tell them what's on the test. Oh, no. Yeah, that's not fair. So y'all get up, get out of here, take a break. It's finally cooled off, hasn't it?
We've been